Welcome to another lesson as we cover meningitis. What is meningitis? It is an inflammation of the membranes that protect the brain and spinal cord, known as the meninges. The most common type of meningitis is viral, often known as aseptic meningitis, which usually goes away without therapy. In AIDS patients, fungal meningitis is prevalent. Bacterial meningitis, often known as septic meningitis, is a highly contagious condition with a high death rate. The prognosis is determined by how quickly treatment is started. For distinct infections that cause bacterial meningitis, there are 3 vaccinations available. For high-risk populations, such as residential college students, 1 is offered. Health promotion and disease prevention. Haemophilus Influenza type B vaccine. Ensure infants receive vaccine for bacterial meningitis on schedule. A series of 4 doses is recommended 2 months of age and 15 months. Pneumococcal polysaccharide vaccine. Though primarily intended to prevent respiratory infection, this immunization also decreases the risk for CNS infections. Vaccinate adults who are immunocompromised, have a chronic disease, smoke cigarettes, or live in a long-term care facility. Follow CDC guidelines for reimmunization. Give 1 dose to adults older than 65 who have not been previously immunized nor have a history of disease. Meningococcal vaccine. Ensure that adolescents receive the vaccine on schedule and prior to living in a residential setting in college. Individuals in other communal living conditions, such as military, also should be immunized. An initial dose is recommended for healthy children between the ages of 11 to 12, with a booster administered at age 16. Assessment. Risk factors. Viral meningitis. Viral illnesses such as mumps, measles, herpes, arboviruses. There is no vaccine against viral meningitis. Fungal meningitis. Fulminant fungal-based infection of the sinuses are from the organism Cryococcus neoformans. Bacterial meningitis. Bacterial-based infections such as otitis media, pneumonia, sinusitis, in which the infectious microorganism is Neisseria meningitidis, Streptococcus pneumonia, or Haemophilus influenza. Immunosuppression. Direct contamination of spinal fluid. Invasive procedures, skull fracture or penetrating wound. Environment, overcrowded living conditions. Expected findings. Subjective data. Excruciating constant headache, nuchal rigidity such as stiff neck, photophobia which is sensitivity to light. Objective data, physical assessment findings. Fever and chills, nausea and vomiting, altered level of consciousness such as confusion, disorientation, lethargy, difficulty arousing, coma, positive Koenig's sign, which is a resistance and pain with extension of the client's leg from a flexed position, positive Brudinsky's sign, which is flexion of the knees and hips, hyperactive deep tendon reflexes, tachycardia, seizures, red macular rash, which is known as meningococcal meningitis, restlessness, irritability. Laboratory tests. Urine, throat, nose and blood culture and sensitivity of various body fluids identify possible infectious bacteria and an appropriate broad-spectrum antibiotic, not definitive for meningitis but can guide initial selection of antimicrobial. CBC, elevated WBC count. Diagnostic procedures. CSF is collected during a lumbar puncture performed by the provider. Results indicative of meningitis are the following. Appearance of CSF, for example, if it is cloudy, it is bacterial, or if it is clear, it is viral. Elevated WBC, elevated protein, decreased glucose, elevated CSF pressure. Counter-immunoelectrophoresis can be done on CSF to determine whether the infectious agent is viral or protozoa. This diagnostic study is also indicated if the client received antibiotics before CSF was collected, CT scan and MRI. A CT scan or an MRI can be performed to identify increased intracranial pressure and/or an abscess. Patient-centered care nursing care. Isolate the client as soon as meningitis is suspected. Maintain isolation precautions per hospital policy. Initiate droplet precautions which require a private room. Continue droplet precautions until antibiotics have been administered for 24 hours and oral and nasal secretions are no longer infectious. Clients who have bacterial meningitis might need to remain on droplet precautions continuously. Standard precautions are implemented for all clients who have meningitis. Implement fever reduction measures, such as cooling blanket if necessary. Report meningococcal infections to the public health department. Decrease environmental stimuli. Provide a quiet environment. Minimize exposure to bright light, natural and electric. Maintain bed rest with the head of the bed elevated to 30 degrees. Monitor for increased ICP. Tell the client to avoid coughing and sneezing, which increases ICP. Maintain client safety, such as seizure precautions. Replace fluid and electrolytes as indicated laboratory values. Older adult clients are at an increased risk for secondary complications, such as pneumonia. Monitor vital signs to assess for septic shock. Medications. Ceftriaxone or cefotaximine in combination with vancomycin. Antibiotics are given until culture and sensitivity results are available, effective for bacterial infections. Phenytoin. Anticonvulsant given if ICP increases or client experiences a seizure. Acetaminophen, ibuprofen. Analgesics for headache and/or fever. Non-opioid to avoid masking changes in the level of consciousness. Ciprofloxacin, rifampin or ceftriaxone. Prophylactic antibiotics are given to individuals in close contact with the client. Complications. Increased ICP. Meningitis can cause ICP to increase, possibly to the point of brain herniation. Nursing actions. Monitor for indications of increasing ICP, which are decreased level of consciousness, pupillary changes, impaired extraocular movement. Provide interventions to reduce ICP, such as positioning with the head of the bed elevation at 30 degrees and avoidance of coughing and straining. Mannitol can be administered via IV. SIADH. SIADH can be a complication of meningitis due to abnormal stimulation of the hypothalamic area of the brain, causing excess secretion of the antidiuretic hormone, also known as vasopressin. Nursing actions. Monitor for manifestations. Dilute blood, concentrated urine. Provide interventions such as the administration of fluid. Monitor the client's weight daily. Septic emboli. Septic emboli can form during meningitis and travel to other parts of the body, particularly the hands, but can occur in the feet as well. The development of gangrene can necessitate amputation. Septic emboli can lead to disseminated intravascular coagulation or stroke. Nursing actions. Monitor circulatory status of extremities and coagulation studies. Report any alterations immediately to the provider. That ends the lesson on meningitis. Check out our other nursing videos to help make studying easier. Also, see below for useful links that take you to Nclex style quizzes, nursing study guides and more.